Okay, so let's start. I think that the schedule that Professor Marcos made is very impressive. The first days we discussed and saw about mind and brain of Professor Sami. They are dedicated to his mind, his brain, his body, his techniques. And today he selected the real soul, the heart of Professor Sami, that is innovation, that is we saw before in the section before, and not invention. Innovation and technology focus on people, on results to improve people's quality. So it's congratulations, Professor Marcos, because you got really the idea. And we're open to commentaries there.
Quick question. So first of all, thank you all for the presentations. Fantastic. My question's for to David. First of all, I'm so glad I just heard the story. That I'm so glad you're doing well. And then, first of all, very impressive what you've your company. Tell us how to invest. You know. But my question is, did you ever think about the medical legal implications? So, you know, many times we talk about things, but then we write in our notes, we go a little more into the depth just for, you know, the medical legal aspects, you know, going through risk. Sometimes you kind of soften the risk when you talk to patients, but in reality, in the notes, you're a little more detailed. And do you ever think about maybe the lawyers will have access to the record, you know, they'll ask, you know what I'm saying, for the record and, yeah, I mean, just wonder your thoughts on that.
They will, and I think we're better off with it. And the other thing is AI makes you, once you have, it's a tool, you know, you have to, now that I'm aware it's there, I talk better and I know it's recording. So if I'll say, well, the risk benefits alternatives to, and I'll I'm not have to worry about writing it down anymore. So it puts it in there. And so, yes, I absolutely have changed the way I talk because I'm more happy about it. I know I'm being recorded. It's going to make my note great. If you don't do that, then, you know, if you've ever done a medical legal case or if you've been sued, the information is terrible. And the lawyers can come up with whatever, they can create any kind of story they want. Frankly, the more information, the better, in my opinion. And our lawyers agree, like in our health system, that they've seen this and they would much rather have this with something maybe missing than what exists now, which is just check boxes and it's terrible. And then they can make up whatever, because all these medical legal cases are just, it's all invented. It's just a game. So yes, I think recording is a good thing. You have patients' voices being recorded. They see that you actually were talking to someone, you were a human. And I think it's beneficial to us medical legally for sure. And I have no fear, none, because I know I'm doing the right thing. And you can still get sued, but I think it's going to memorialize that interaction, which is, I think, far and away better than we have now.
David, can I ask a question? First of all, it's really exciting. I mean, this thing,
Yeah.
we all know, we all need that. But can you input this thing can you transcribe into the medical record, the electronic medical record?
Yes, we're integrated to Epic. You know, what's even going to be more interesting is, I think, if you think about it, we're going to get rid of computer keyboards are going to go away. This whole EMR interface, which is just atrocious, is going to go away because you'll just talk and say what you want. I want, you know, what the orders are. It's going to record a conversation, create a note. It'll do the billing for you. This is all not that far away. We're probably talking less than 5 years in the United States. We're not going to have these, or you'll ask it for information. I need the chest X-ray report on so-and-so, and you'll get it on your phone. And so we're going to see a very rapid iteration of this because of the real massive benefit this has to healthcare providers. Think about residency training, discharge summaries. I mean, it's
no, I mean, this is great, but right now, if I want to use
absolutely.
it right
It'll
now,
integrate, yes.
I need to put it into the medical record.
It's integrated. Once that note's made, this is a free version,
Uh-huh.
but when your hospital, when you have an enterprise version, that note will get directly into the patient's chart.
Huh.
There's a whole question whether allow editable. We allow editing first before it goes. So it comes up on your phone. You can edit it or on your computer and then send it. So we have an opt-in rather than opt-out. You can there's some companies that want opt-out, so it'll automatically go in and you edit in the medical record.
Mm.
So we wanted people to edit it, be able to edit before it goes. And it's a question of what's better, which causes more friction. You know, I think doctors want that control. You could argue that you can actually flip it and have it automatically go in and edit in the medical record. But, you know, that's just the way we designed the
Great
workflow.
Yeah, I fully agree with you. It's, I think the technology is here, and we as a physician, and I'm a neurologist, and you're a neurosurgeon, majority here neurosurgeon, we should be involved with that design and application, because otherwise we're going to just left behind, and then we kind of quote unquote bitch and moan about the program not this good, but we should have been in there in the first place. So you're absolutely right. I fully agree with you. And the good thing is UT Health actually is collaborate with OpenAI now. And using everything. Jia Zhang is our dean for the SBMI, that's the Institute for the Big Data. These are going to work everything that's possible for clinical applications using the technology. And the one thing I have a question for you is, let's say I have a patient with Spanish speaking, and then I interview him or her, and then at the end of the day, I say, I want to have a Spanish version for the patient. You should be pretty quick, right?
Yeah, we're already doing that. We have about 12 languages. We have Mandarin, Chinese, Taiwanese, Chinese, Spanish, Brazilian Portuguese, because we're in Brazil. We have working with a group in Brazil. You can, that's so easy.
This is
And
one command. And
you
that's
can
gonna
actually
give
you can
different
actually
words.
record the conversation in one language and convert it to another, or vice versa. It's going to solve so many. Think about discharge instructions and things that are just, you know, we talk about culture and world nurse. Then this is super cheap. You know, I think for one thing to do as far as global, this is something you could do tomorrow. I mean, it's just not hard to do. It's not even equipment. And the third world all have mobile devices. And so the whole way medical record can be created and stored is going to change, in my opinion.
Yeah, the last thing is about the imaging. Let's say I want to have, you know, including the flare, axial view, and or
Yeah,
T-virus
so
contrast. That
recording-
easy to do as well.
Yeah, recording screens is super easy. And in fact, the data storage, if you make a recording of an MRI, the amount of data versus the DICOM is about less than a tenth. Because the way that when you make a recording, what only is stored is the pixels that change. So when you cut through an MRI, the number of pixels in that change in the entire, say one series is still a minority of the overall pixels. And so when you record a screen, you could record the entire MRI, scroll right through it, and recording that and storing in the cloud is much, much less storage than the actual DICOM set. That's just the cost savings. But then you have, it's basically a highlight reel. So if I make a video of your MRI, I don't send you the whole MRI. So here's your aneurysm, this is what we're planning on doing. And there's all this data that I just ignore. And so, you know, a 30-second, 1-minute movie of the MRI. And then I have that as my kind of like highlight reel. And that can be shared, give it to patients. It's a brave new world. It's just a matter of us taking advantage of it.
Thank you. Dr. Clara Epstein. So back in the 80s, I was involved in the first informatics workshop. I have a background in medical informatics as well and presented with multilingual EMR systems. And that was one of our greatest challenges, was converting from English to other languages, not just because of translation directly, but because of cultural translation interpretations. So I think now with AI and some of the technology that we have available, it's very helpful. I also wear another hat as physician wellbeing chair in the state of Colorado. And one of the biggest burnouts and attrition rates is based on all of this hard work that we have to do that's impacting everybody and really not allowing us to focus on the primary responsibilities that we would love to do. And I think this is a really wonderful integration for both Epic. And I didn't know if you partnered with Athena Health yet, if you had an enterprise system, but I highly recommend them.
Happy to with anybody. We're looking.
Yeah, they're amazing because they also integrate. So it's kind of the downstream. Thank you for what you're doing. I think it's really amazing, and being able to record and again, having paper trails for medical legal reasons, you know, being able to see the modifications and so forth, I think are really important. So as a physician or neurosurgeon changes either their operative report or whatever it is, I think it's important to be able to track that because the more documentation that is available from a medical legal perspective is very helpful. Thank you.
I mean, what's your expectation on what will be better with this neurobionics that you are enthusiast some years? What do you think that will change in quality, considering other kinds? And do you believe that these neurobionics will go on other sensations that are injured?
Well, I've presented two different implants. One is the midbrain implant. This is obviously, you know, we talk about industries, and you can imagine the ABI that is existing now is a niche product for the big players. So whether it's Medel or it's Cochlear. So they don't invest a lot of money, very few patients. That is a little bit the downside for the further development in the field. So hopefully the companies will go this way with us. What we hope, and what I said also, is to overcome the limitations we have in NF2 patients that have, radiation, surgery, etc., and they have somehow injured, distort anatomy around the cochlear nucleus. So when we go up there, but this is 12 cases so far, and again, it's a niche product also for the industry. So we need NIH and DFG money to push this further. It's a bit different with the ANI because the ANI is something that is competing with the cochlear implant. So that's a big business. You have big players in the market. In the US, you have big companies. You have one in China, you have in Australia, and you have Medel. So they're getting nervous because it is, I've shown you, it's very clear. If you go directly into the nerve and you don't harm the nerve, obviously you have a much better access. The data can be transmitted much more directly into the nervous system than going through the bone and the cochlea. And I think, after we've shown in such a sensitive nerve, and we've seen many lectures, we all do surgery around the cochlear nerve. And when we are just afraid to push it too much, so the patient is deaf maybe. But here we put the electrode inside. So I would say this gives us hope also that we may use this electrode not only, it does exist for peripheral nerves, but maybe also for other cranial nerves. That's an option, but I think our focus now is on the ANI, and we really want to make this fly, and it could be a game changer for hearing restoration. Yeah.
Just one quick question about that. Why make, when the sort of vagal nerve stimulators, they make that kind of like curly cue around the pigtail. Why? It seems like rather than something that would be less traumatic, just to wrap a electrode around the nerve rather than sort of the
then you
pinhole.
need to increase the current to reach all the fibers in the depth. So the idea of penetrating is that you are, because you have a tonotopic architecture within the nerve, you want to reach as many fibers as possible. That's why.
Makes sense.
Amir, how do you assess the health of the nerve before using it? How would you know?
That's what I said. What we do is in our series now, we do the translab test. That's why we put a test cochlear electrode through the round window, we stimulate, and then we see we can pick up signals in the brain. Then we know the nerve works. Then we take the tumor out and we test it again, see it's still healthy. So in case, if we think now of our, let's say, retrosic surgery, what we would do is we would take a direct stimulation on the nerve, like with the ABI test electrode.
Okay, yes, we're on time. Thank you very much.